Welcome to those of you who are joining us. We'll give everybody a few minutes to join. But in the meantime, if you want to share where you are joining us from in the chat, we love to see who's joining us. So yes, just give us a few moments to let everybody get settled, and then we will begin the webinar. Great. Looks like we have folks joining us from all corners of the globe. Some new faces, some familiar faces. We'll just give everybody another moment to join, and then we'll get started. All right, it looks like we have reached a kind of a peak point here with our attendees, so we'll get started. Welcome everybody. My name is Christina Villela. I am one of the co-chairs of the Global Digital Health Network. One of my other co-chairs, Steve Allis, is on the line. Steve, I don't know if you want to say hello. Not to put you on the spot. We'll keep going. All right. So yes, welcome to our monthly meeting. We are really excited for today's topic, looking at applying to data science to public health, and we're really excited. We have a wonderful group of panelists that Path has helped us put together. So before we get started, though, I just wanted to go over a few announcements from the Global Digital Health Network. First, I am sure all of you are chomping at the bit to learn more about the Global Digital Health Forum and the registration to open. So in case you did miss the announcement, we are going to be a fully virtual conference this year. We're really excited. We have a vendor that we have selected for this conference, and we're really excited for all the different features that we'll be able to provide to really create a conference that tries to mimic as much of our in-person conference as possible, while also kind of expanding the capacity of how many people we can have attend. And we won't have some of the barriers that we've had previously of travel and things like that. So we're really excited. The conference will be hosted December 7th through the 9th. Registration should be opening within the next week. And abstract decisions, for those of you who are waiting for decisions about if your abstract was accepted, those will be forthcoming as well in the next week or two. So you can see here we have, if you want to learn more about the conference, you can go to bit.ly/GDHF, make sure you capitalize that 2020. And that'll bring you to our website where you can get more information. And if you want to be the first to know when we open registration, I highly recommend that you join our listserv. For those of you who found out about this webinar from Twitter or LinkedIn, the Global Digital Health Network is actually much more than a set of meetings. We are a very active community of practice, and we host several different, we host monthly meetings as well as deep dives throughout the year. And we host the Global Digital Health Forum in December. And we have a very active listserv where people share and information with each other, and it's a space where people can collaborate. So please do go to that bit.ly link to sign up for our listserv. GDHN is capitalized there, and then sign up is not. So it won't work if you don't use the capitals. So yeah, we hope you'll join the network. So now I'm just going to introduce we'll go over some housekeeping items first. So please do keep yourself muted, although I think because we're in webinar mode, we control that, but do try and keep yourself muted if you have the ability to unmute or mute. And then if you have questions for the panelists, we'll be doing questions at the end. So there's going to be a few presentations and speakers, and then there's going to be a moderated Q&A, and then there'll be open Q&A from participants. So if you have questions for the speakers, please put them in the Q&A box. You can find that box at the bottom of your screen. Please use chat. You can chat the panelists if you are having any tech questions. We'll be here. And yeah, we're looking forward to an engaging webinar. So without further ado, I'd like to introduce our panelists. Well, Emily is going to introduce our panelists, but Emily Carnahan is joining us from PATH, and PATH has organized a wonderful panel here to talk about applying data science in health. And we have speakers from the Rockefeller Foundation, DataKind, and Wadhwani AI, and we are really excited. So I'm going to turn it over to Emily, who's going to introduce our speakers and be our moderator for the day.
Great, thank you, Christina. Thanks for the introduction. And thanks to everyone for joining. It's great to see in the chat the variety of people that are on from different organizations and different locations. So my name is Emily Carnahan, and I am a manager on our monitoring, evaluation, and learning team at PATH within our Center of Digital and Data Excellence, or CODE as it's known. I've been at PATH for about 7 years now, and a lot of my work is really at this intersection of data science and health systems and digital health. So really excited about this topic today, and really looking forward to digging in more to data science with our great panelists. We've really seen that with the scale up of digital health tools and systems, this has significantly increased the amount of data available. So there's so much utility to use that data in really meaningful ways to strengthen health systems. And really thinking about, that full spectrum from data capture to data transformation to analysis and visualization and use. Really want to talk about the ways that we can use data science tools and approaches to really apply it to global public health, to turn data from just data into insights. So we're hoping to talk about some of the ways that data science is currently being applied. What are some of the barriers to using data science? Also some of the facilitators for kind of supporting that full ecosystem for data science approaches, and how we can better support countries in applying data science to global public health. So with that, I would love to introduce my excellent panelists that are here to talk about these really interesting questions. So first we have Manisha Bingay, who is a Managing Director for Health at the Rockefeller Foundation. Manisha leads program strategy and manages the portfolio of implementation partners for the Rockefeller Foundation's Precision Public Health Initiative. She has over a decade and a half of experience in social innovation and implementation science in global health. Prior to this role, she created and led the Strategic Partnerships Office at the Tata Trust, India's oldest philanthropic organization, and launched the India Health Fund, a leverage fund in collaboration with the Global Fund. In addition, Manisha was vice president at BRAC, the world's largest NGO, for over 6 years, where she developed and managed programs that promote access to health, education, economic empowerment, and social justice. She has worked extensively across Africa and South Asia on community-based service delivery and women's health and empowerment. So welcome, Manisha. I'm also going to introduce our other two panelists. Raghu Dharmaraju is Vice President of Products and Programs at Wadhwani AI. Raghu has over 2 decades at the intersection of technology and social impact, and developed, launched, and/or scaled innovations in AI, medical technologies, rural energy, and transportation in Fortune 500 companies, startups, governments, and nonprofits. As part of the founding leadership team at Wadhwani AI, he helped grow Wadhwani AI into a globally unique institute developing AI-based solutions in maternal and child health, tuberculosis, cotton farming, and now COVID. He is an alumnus of Cornell, UMass Amherst, and IIT Madras. Welcome, Raghu. And last but not least, Caitlin Augustine is the Senior Director of Product at DataKind, which is a global nonprofit that harnesses the power of data science and AI in the service of humanity. As the Senior Director of Product, Caitlin is responsible for delivering DataKind's core offerings, ensuring that high quality, impactful data science interventions are delivered within the social sector. Caitlin oversees DataKind's frontline health systems impact practice and is thrilled to work with and learn from so many members of the Global Digital Health Network. Prior to DataKind, Caitlin worked as a research scientist at a digital education company and as an engineering professor at NYU. A lifelong volunteer, she is a tutor with the Adult Literacy League and a leader of a community civic tech meetup. Caitlin holds a BSIE and a PhD from the University of Miami. So as you can see, we have some great panelists with us today who have a wealth of knowledge in different sectors applying data science. So with that, I would love to hand it over to Manisha to make some opening remarks about how data science applies to the work that you do in global public health.
Thank you, Emily, and welcome everyone. It's a real pleasure being on this webinar. Just to start off with, the Rockefeller Foundation, as many of you know, we are a 107-year-old philanthropy. When you're over a century old as an institution, you've seen a lot. And one of the things that we have focused on over our century worth of existence is science-based philanthropy. And when we kicked off our strategy to identify what is the critical scientific advantage of the 21st century that we need to bring to the development sector, we identified data science as a key area and found very quickly that in public health, it has been a laggard. And the question poses itself, why are we not using digital technology, data analytics, data science in a concerted way to drive effectiveness and impact in global health? That body of work and that analysis kicked off an initiative which we launched last year called the Precision Public Health Initiative. And very broadly and in the simplest terms, what we mean by that is how do we use data and digital technology to ensure that the right people get the right health services at the right time. And what you'll hear with that is data analytics, and data science is of service to key people. I think, when we think about who those people are, I want to draw out a couple of archetypes just to give an illustration of what we mean when we put that terminology up there. Let's look at 3 users, if you will. The frontline worker. Let's look at a community health extension worker in Ethiopia. She starts her day with rounds, household rounds, as well as a time in the facility. How does she choose who she sees, why she's seeing them, and how does she manage her time? Remember, we are working in geographies that are highly resource constrained in manpower, constrained in skilled workforce, constrained in financial resources, and weaker health infrastructure. So within those, we need constrained optimization, to use a mathematical term, at various levels. So a community health worker, when she starts her day, should have the ability to understand where she's needed the most, what her catchment area looks like, what's the story of her village, and how does she plan her day to make the most effective use of her time, her abilities, and the resources. Let's go a step higher to the district level. the district health officer has a different set of questions and a different set of constraints. He has to manage budgets. He has to manage resources. He has to plan a workforce. Does he have the information? Firstly, if he has the information, is it organized in a way that allows him to make those decisions very quickly? And then, does he have the ability to actually action on those decisions? Those are constraints that we think about at the district level. Let's take it a level further at the national level. Let's look at the lead for an EPI program. A very different set of challenges and problems and different decisions. Also, that needs different set of informations, different kinds of decisions that they need to be processed, and then different actions that they may or may not be able to take based on those decisions. So looking at these three archetypes, we launched the Precision Public Health Initiative with the idea that we want to build capacity across three levels. The first is, can we ensure that we get the right information in a timely manner? So accuracy, availability, and timeliness of information. In this case, digital information. We call it data. Data could be analog or digital. Is it available? That requires investment in national digital health platforms. I think if we don't have a reservoir or a continuous reservoir of information and data, doing any analysis becomes difficult. So timeliness and accuracy, availability are critical preconditions for any form of analytics, may it be basic analytics or more advanced, sophisticated data science like predictive analytics. And we'll talk a little bit, and the panelists on this webinar will be more conversant in the more sophisticated nature of some of this work. That brings us to the ability to make sense of that data. And that also falls over a continuum of opportunities. We can go with as simple as let's visualize what we have and make sense of it in that way. Put it on a geospatial map. That does not require a lot of sophistication, but creates a picture of the data of the information that may not be feasible in a broader table. I think most of us who have worked at the country level have seen pretty robust PDFs of data tables in annexes. Are those any use? I think broadly everybody, it would be very hard to identify or find anyone who would agree with that statement. However, putting those on a map, putting those in perspective to the problem, the context, the catchment area suddenly brings that information to life. That's what we mean by data analytics. That can be in a vast continuum. We can start with a basic visualization. Let's make sense of the data we have. Let's start processing that information with other sets of data points from different sectors. That changes the nature of what we are seeing through that data. Let's take it all the way to the other end of the continuum where we have more sophisticated data analytics, where we are looking at panel data, longitudinal information to actually start forecasting where the world is heading and where challenges that are not imminent today are likely to, we are likely to encounter tomorrow. All of that requires, different players, different ecosystems, and different types of investments to concurrently be active. And this is not unique to data science in global health. It's prevalent wherever we see an evolution in scientific capacity. An example that is very commonly used is the GPS, and the fact that Google Maps these days can tell you where the traffic is, give you alternative directions, and in real time. Those of us who are old enough on this webinar will remember GM's GuideStar in the 1990s. Mapping existed in the 1990s. It was less sophisticated. So we evolved over a period of 20 years to what we have Google Maps today. So I think where we think about leapfrogging, I think the timelines have condensed, but we need to understand, we need to evolve across the continuum of data analytics based on what is available. How do we make the best use of the data that we have to deliver the most value to the key users. And do the users, I think this is where data use as a construct also plays a significant role, because we need data consumers and active data consumers wanting to participate and demanding quality data and analytics. And to do that, they need to have the right incentives, the right motivation, and the authority to make decisions. Otherwise, the cycle of from collection to processing to use will not be a virtuous one. We will get stuck halfway, and then we have innovations that don't get to scale. Just quickly concluding, we started our initiative and our body of work fairly recently. So we launched middle of last year, but we do have some early insights and early lessons, especially through our partnership with UNICEF that works very closely with countries, especially in India and Uganda. And what we have learned is there is intrinsic interest and need for this body of work, but understanding the biggest challenge that we have seen is just having data. The accessibility, availability, and accuracy and timeliness of data is a critical component to make the data analytics relevant, feasible, and trusted. And once that is trusted, I think it'll unlock consumerism or analytics consumerism across our key stakeholders. So with that, I'm going to close and just say that never before has this been more relevant than today during a global pandemic, where we need information, we need to process it quickly, and we need to respond because lives are at stake. And while this interest was there 6 months ago, it is even stronger now. And the opportunity that is with all of us today is how do we use the lessons that we learned and the needs that we are seeing today to build back better and stronger and prevent not only the next epidemic, but probably strengthen health systems to prevent mortality and morbidity at large. Thank you.
Thank you so much, Manisha. It's great to hear more about the Precision Public Health Initiative and the focus areas there of really thinking about the data itself and making sense of the data and moving all the way through to using the data. And great to think about who are the different end users of that data as well. So thank you for those comments. And with that, I will pass it over to Raghu. And I have your slides up, so let me know as you would like me to advance them.
Sure, great. Thanks, Emily. I hope everyone can hear me. Okay, great. So Manisha, thanks for setting that up very beautifully. You covered a real breadth of background in terms of both the potential of data science as well as why it's really required. So let me jump into a little bit of nitty-gritty of how we've been trying to build AI for the next 5 billion. And when we say the next 5 billion, these are basically really the bottom of the pyramid users who continue to rely on large-scale government and nonprofit programs for their basics, including health, right? We are a 2.5-year-old organization formed precisely with that as our mission. And we've grown quickly to do a bunch of things. Let's go to the next slide. In maternal newborn child health, I'll talk about a couple of things, but mostly I'll actually focus on what we call the visual weighing machine for babies. And I'll talk about the motivations for that. TB, we are working on a bunch of things, including treatment adherence. We all, folks in global health know how big a challenge it is. And of course, screening and diagnosis. And we are doing this in collaboration with India's national TB program. Agriculture is also one of our programs we had started pre-COVID. One big project there is pest management in cotton farming. But COVID really pulled us real time into supporting cities and states in COVID response. We initially did that through the consortium, and we went really deep with Mumbai, which has been the epicenter of the pandemic in India. And yeah, we also have some great results on cough against COVID. Let's move to the next slide. So like I said, I'll focus on a little bit of the how and nitty-gritty of how we do things. But key to it has been really a radically collaborative approach. Typically, technologists and global health folks are in two different buckets. So under our umbrella, we bring not just AI research, engineering, product, and design, but also folks from the programs, but also of various types, administrators, implementers, and domain researchers. And we work with external partners themselves very closely. And that to me is the huge difference that it makes a big difference. And I also think that's the missing ingredient for a lot of the last 2 decades of technology not quite taking hold and scaling the way we had hoped for. And COVID certainly showed us up in our lacking. Next. And when we say AI-based solutions, we mean everything. When you build a recommender system on Amazon, you don't have to worry about whether that product will actually get delivered, right? And the customer has a way to rate it so that you close a loop and you learn from that and you build AI, right? Your workflows and data pipelines, everything's working perfect, right? But in public health, next slide. We don't, the previous one, yeah. We don't have actually very good closed loop systems at all. In fact, if you are able to connect the upstream actions that are required for AI to actually be used and make sure that the downstream actions actually happen, then we are good. So the way we define AI-based solutions is not just about AI, but the products, the data pipelines, and the workflows together. Next. And hence, before we actually pick up problems to work on, we not only ask whether it's an important problem to solve and whether there is an AI-based solution possible, we ask whether AI actually can make enough of a difference. There are 2 situations in which AI won't make a big difference at all. One is maybe simpler systems, such as maybe rule-based systems are good enough. Maybe simple heuristics will be good enough. And in some situations, even if you do AI, there are other things due to which actually you won't have impact. And of course, stakeholders and users and beneficiaries acceptance. Here, stakeholders aren't just the officials, but really the beneficiaries and users too. Without data, there's no AI. And ultimately, you can't do anything without having programs and pathways to scale and organizations to partner with and co-create. So let's jump in to the next slide. Many of you might recognize this as birth weights of babies. Clearly, we all don't believe it, but we all also know, unfortunately, how poor the data in our global health systems, the IT infrastructure actually is. And why does this happen? Next slide. Anyone who has used it, even a digital spring balance on field, knows it takes 2 to 3 people to actually do this properly. And of course, it's very easy to fudge data, and lack of verifiability also means lack of accountability. And that's at all levels that Manisha has described. But so how do we make this easier? And of course, there's repair issues. How do we make this easier? Let's go to the next slide. So we have actually built a visual weighing machine. We have some great results. We are at plus or minus 140 grams. But the point here is by simply moving a regular phone, no additional hardware, over a baby, we actually get not just weight, but we could also do other anthropomorphic measurements. And we are actually on a path to compress this so that it can work offline on a phone. Now, this all seems like a lot of overkill, a really fancy technology, but this is something that has huge potential because now you can imagine extend it for the growth tracking. And if you think of weighing as just an initial use case, think of what else you can infer from that one particular few seconds video you take of the baby. Next. And it's happy to report that we are also doing well in field settings, more work to be done. COVID has definitely set us back, but we'll get there quickly over the next few months. Next. Ultimately, the promise really is not, we are not just, it's not about AI at all. The point is that we want to simplify the overall system, right? This can work with any app. You have time-stamped, geotagged measurements. It can integrate with existing systems. In India, for example, the reproductive and child health IT systems. you have the home-based newborn care workflows and data flows, right? And at the end of the day, hopefully we stop doing repeated transcriptions of the same thing from one register to the other and data entry operators, etc. And folks up the chain actually receive real-time data and are able to follow up on the babies that really need care. Maybe we don't need to do everything for everyone. If we just focus on the most vulnerable babies, and those we know are low birth rates, I think will make a big difference. Next. I'll also quickly touch on our COVID work. This is kind of fresh off the press sort of update here. We have been very involved in a 20-center multi-geography IRB approved data collection effort. We got started in several states in India. We have great results even for asymptomatics, and we think it has potential to boost overall testing capacity, which we all know is a big challenge across all countries. We're currently in validations and figuring out deployments. If you are interested, do reach out to us. The big promise here is, again, you don't need any additional hardware or software, and just solicit at cough. Next. I'll spend just a couple of minutes on this. Now, if there's something that COVID told us, that it's that we are not pandemic prepared at all in many ways, right? And you'll see back in 1918 with the Spanish flu, that was the first time when scientists said, hey, we should be using data to understand this. 100 years later, we are still not there. That said, we've found some amazing partnerships with cities, as well as a bunch of collaborators who came together under what we call the Data Science Consortium. And we ended up actually focusing a lot of our energy in Mumbai. So from helping them clean up data to using some advanced techniques to do data smoothing, to doing projections with uncertainty estimates, because that's important to actually figure out what scenarios you want to plan for, to getting granular sort of estimates for resources. We even did estimates for nurses and hospital staff, that sort of thing. So that was all modeling, but typical SAR modeling coupled with machine learning for parameter fitting, etc. That's what that was. But it also had a very important service component, without which all this data science would have been useless, right? And more recently, we've been doing other things such as prevalence estimation. Sorry, I masked some of this for confidentiality because we work very closely with the cities and states. And also helping them target problematic areas within the cities where we are seeing, high test positivity rate or CFR, and helping them understand where they should be ramping up various types of services, including tests. And ultimately, we are building a pandemic management system. Next. With that, I am done. Happy to take any questions at the end.
Great, thank you so much, Raghu. It was great to hear more about some of the examples of what Wadhwani AI is working on. And I love this phrase that you use of a radically collaborative approach, and bringing together all of those key audiences and partners to take the work forward. Thank you for sharing those examples. And yes, as Raghu said, if anyone has questions, feel free to be dropping them into that Q&A box on Zoom, and we will have time for those at the end. With that, I would love to pass it over to Caitlin to talk a bit about your data science related work at DataKind.
Perfect. Thank you so much, Emily. And I'm thrilled to be the third presenter, because I think my comments will really be an enthusiastic +1 to both what Manisha and Raghu said, that similarly, we have done a lot of discovery around data quality and the access to data as one of the areas data science and data scientists can improve, and agreed, Raghu, that we need these radical collaborations as a way to really push the sector change forward. So we'll definitely love to tell you a little bit about DataKind if you can click to the next slide. So DataKind, we are an international nonprofit organization focused on harnessing the power of data science and AI in the service of humanity. We've been around for about 10 years now, and we've done over 300 projects working with social sector actors to help them improve their ability to achieve their theories of change. So we view data science as one of many tools in a toolbox, and if we can apply it to social sector actors and their problems to help them reach more people, save more lives, use resources more effectively, we consider our work well done. You can click on to the next slide. And the types of problems that we are really focused on solving are what we call wicked problems. Problems that are difficult or even impossible to solve because of incomplete, contradictory, and changing requirements. For example, how can we say we've solved poverty? There are so many levels to trying to solve these big sector-wide problems that no one individual project or no one individual actor actually has all of the resources to solve those problems. And that's why DataKind has started this approach to problem solving that we call impact practices. So if you click on to the next slide. So this idea, similar to what Raghu said about radical collaboration, rather than DataKind focusing on one project in education, one project in frontline health, one project in microfinance, what we've said is we are focusing deeply in these impact practices, in these issue areas. We are going to embed ourselves in these sectors, learn from experts like you all on this call here, and we're going to commit to work in this space for a number of years so that we can build solutions that are code bases, frameworks, tool-based applications that are of use across a sector. And so we came to this with a question. If you click to the next slide, just literally saying, what are the data scienceable problems in frontline health? And the way that we approached solving this and actually coming up with an answer to this question was, if you click to the next slide, following what DataKind calls the 6 components. So you can't just say one organization, what's your problem, and assume that that solution will scale to many other solutions. What DataKind did is we actually had over 100 conversations with actors in the space. We talked to subject matter experts who have been working on the ground for decades. We talked to social actors, those who are leading these NGOs and other organizations who are attempting to make a major difference in the world. We talked to expert funders like Manisha on the call here who are deeply committed to making change in this particular space. And then, yes, we have talked to data scientists like Raghu's team to say, okay, data scientists, what can be done in these resource-scarce environments with this sparse data? We looked to say, what is the data that is available here? What's publicly available? What's privately available? What happens if we pool those data resources? And ultimately, we came to a conclusion of saying there are a number of problem statements that are useful to solve at a sector level. And if you click to the next slide, I'll quickly highlight those. What we found was that increasing the amount of digital data available is a key problem. And the way that DataKind has approached solving this is through a paper to digital data transfer. So we've worked with a number of organizations who collect data in standardized written forms and said, okay, what if you were able to take a picture of that form and have that picture go through an image detection algorithm that then populates your computer database? So rather than having a human sit and do an excessive amount of typing at the end of a month or end of a reporting period, could we do this on a daily basis, on a weekly basis? The next problem that we found that was continuously brought up was, okay, we have digital data. How do we increase the confidence in that digital data such that it could be used for data science, such that it could be used to help solve these resource problems? So what we said is, you know what, at a platform level for these digital data collection systems, we need to have quality assurance. We need to have anomaly detection, and we need to actually have remediation efforts, because just identifying bad data isn't enough if you don't know what to do with that bad data. Sometimes bad data is a typo where you say someone is -5 years old rather than 5 years old. Sometimes it's far more complicated. So understanding what those data issues are and if there's a pathway to remediation is key. The third major area that we found was, okay, if you have digital data and you have confidence in that digital data, how do you actually use it? So where do we actually see opportunities to use this data collected? This could be in resource allocation. It could be in risk modeling, so identifying patients that have the highest need and therefore being able to send your frontline health workers to visit those particular homes and locations. It could be predictive tasking, saying rather than just going sequentially through a patient list, we're going to only visit these patients on these days because of this XYZ set of results. And then lastly, we saw that we needed to increase the capacity of frontline health teams. This is both in their data science capacity, so how can frontline health teams be made more data aware and data literate, but also can we use data to improve the frontline health team capacity? Can we enhance training programs? Can we make those more proactive rather than reactive? Can we make them more lightweight? For example, can we see there are clearly components of training that, if completed, lead to better health outcomes? We recognize one of the major issues in frontline healthcare is really simply having enough frontline healthcare workers. So if you can train your workers more efficiently and to produce the same care results, you'll have more health workers operating within your particular system. So out of our 100+ conversations, this is really what we distilled as the issue areas. And for the past year, we've been working on a cohort of projects focused on attacking each of these problems and developing prototypes that we believe could be scalable to multiple organizations. And if you click to the next slide, I have a little bit of information about these particular projects. So we've been in a number of conferences, we've presented a number of papers, we've shared a number of blog posts, really talking about how these solutions have been successful and frankly, some of the challenges with them and what our next steps are. So for example, engineering scalable data quality for frontline health. We worked with Medic Mobile in one particular deployment. We are now working with not only Medic Mobile, but a number of other platform providers for digital health case assessment to build the same set of data quality assessments onto their platforms. So rather than one actor, multiple actors. We worked with Riders for Health on this digital data transformation. You can see the pretty bold headline, saving time and saving lives. What a great outcome. We don't want that to only be for Riders for Health. So we've taken the tool that's working particularly for them with specific health forms in Nigeria and said, what happens if we make this for health forms that are standardized to the World Health Organization, such that many more organizations could use this OCR technology. And we've talked about a number of our interventions that we've deployed with Jacaranda Health, our third major partner here. Jacaranda Health runs digital training programs. What can we do to make those training programs more lightweight, more customizable? So all of these are public links. Glad to share them if you can't find them yourself, but want to say it's been a real thrilling past year to see, yes, there are solutions that can be generalized and can be scaled. So if you just click to the next slide, I'll close with a little bit of just some of our learning. Say, you have to de-risk the space. And I think that that's a conversation all three of us will be having in the next part of this conversation, that first actors need to be able to say, this is your problem and let's try to make a solution for it. And sometimes we'll fail. And that's why you need data-driven groups like the Rockefeller Foundation, like Wadhwani, like DataKind to say, we have that expertise, let us build you the prototype, let us show you what's possible. We need to focus on the critical problem. And this is something that DataKind really learned through this idea of, we're gonna jump in with risk modeling first. Modeling, right? That's data science. But if you start with risk modeling and you don't trust the data you're building the models on top of, what good are your predictions? So this was a humbling experience to say, risk modeling, that's one of our 4 key problems. There are some other steps that need to be done first. Another thing to say is you do not need to be high tech to see the benefits of a high tech solution. Image detection modeling or optical character recognition, intelligent character recognition, that's a big word salad. Like that's technology that is a research hard problem. But what it ultimately means for an end user is you can take a picture and know that that picture is converted to text. And all you need is a phone that can take a picture to do that. So you don't have to be high tech or high data science in order to see the advantage. Another learning here is your solutions won't work unless they are overseen by the people doing the work. You want a successful data science solution to be pushed down to the lowest level in your sort of work totem pole. You want your community health worker to understand the value of your data science solution and feel empowered to use that information and to interact with it. And then lastly, as I sort of started with, one organization, one actor, one solution, that's not enough. The essential way to use data science to improve healthcare and health outcomes for millions is to work with partners and platforms in order to scale those solutions. So I will close with my plea to action, which is please join us. So if you just click to the next slide, have my email address, have our DataKind Twitter handle, have our hashtag, but please continue to work with us, help us scale, help us create these data science solutions that will serve the good of many.
Thank you so much, Caitlin, for that great presentation. Really great to hear about DataKind's approach to this work and how you're going about de-risking the sector. I think that this idea of identifying data scienceable problems really resonates and has resonated when we've talked about this with wider groups in talking about data science. So thank you again to all of our panelists for those opening remarks, and now would love to have more of a discussion. So that's the first question I would like to pose to our panelists is, how do we think about these data scienceable problems? What makes a health system challenge data scienceable? And I think Caitlin raised a really excellent point to this is, how much do these data scienceable challenges vary across contexts? So how do we think about kind of identifying some common data scienceable problems? How do we think about adapting them to the local context, but then finding the threads in them that can help them to scale across contexts? So would love to hear comments. Maybe I'll start with Manisha and then move to Raghu and then back to Caitlin.
Thanks, Emily, and that's a provocative question, isn't it? And I think Caitlin really put a good framing around it. From the foundation standpoint, I think we see data scienceable as another framing for actionable. Is do we have let me back up a minute. Let me break that into 2 components when I say actionable. As first is, what is the science piece of it? And then what is the scienceable piece of it? To that end, being able to process data in a way that actually aligns with a decision that is actionable in some way is, I think, how I would describe it. And to give some color to it, let's look at an example, right? I think the best way in the world of frontline health systems, there are multiple types of information and data points that can be collected. There is catchment area data in terms of, let's say, mortality data, prevalence data, service data. Those sit in multiple silos. There is also non-health data, which is relevant, such as seasonal changes, monsoons are coming, and patterns that emerge based on those 3 groups of information and sort of external information. Being able to process that is science, data science. Making that worth someone's time to action, I would say, is data scienceable, because we could come up with a really beautiful map of where the next sort of cholera outbreak is going to be based on what has happened in the past and where the patterns, monsoon patterns or weather patterns are. But if that information has no value to the key users at least, I would argue that is not a problem that needs a solution now. We have just created something that's very interesting that is not targeted for you. So I'll stop there, but I think that is from an analog standpoint how we see what can or cannot be data science. When it comes back to the user, what the problem is, and how do we develop solution sets using data and analytics to deliver that.
Thanks, Manisha. Raghu, any reflections on this idea of identifying data scienceable problems?
Yeah, sure. I'm going to reframe data scienceable problems as problems that can be solved using data science. For them to be solvable using data science, it has to meet 3 or 4 criteria. One is, of course, that data science, you first need the basic digital infrastructure to bring you the data in, and it has to be reliable enough to begin with to do that, right? In the case of the anthropometry solution I showed, I said, you know what, we are not going to trust written hand-prescribed measures. We are going to just rely on an image. That's with the geotag, you know exactly where it's taken, when it's taken, etc. The second is, will it actually make, is there actually what do you say? Is there a data science solution? Is it technically feasible, right? You can predict all you want with data, but first of all, it has to be technically feasible. The third one is that, okay, now that you've did some fancy AI, is it actually going to lead to any benefit? Which means the workflows need to be in place, and it should also make enough of a difference. If the same thing can be solved using a simple heuristic, you probably don't need fancy AI, right? Then don't try to solve it using fancy AI or even complicated data science. At the same time, you might solve that, and if you still can't get care to the baby, you might diagnose but don't get the medicine. You need to solve the other things before the data science itself make a difference. That's not to say, I do think data science has huge potential to show up the issues in our system, right? But for example, what is the real prevalence of low birth weight babies? So when you have something that is non-fungible as a tool in the hands of the frontline health workers, and also something that makes life easy for them and provides value by giving them something that using which they can immediately provide some advice, right? Because it has to be worth their while, right? Then I think that's when you really crack them.
Great, thank you. Caitlin, any additional thoughts from your side?
Yeah, so I'm just going to share to everyone this article on leverage points and places to intervene in a system. It's a really great article that outlines 10 points where you can actually really sort of meaningfully intervene in within a system. And you can see that not all of them could be solved with data science. So it's important to understand if the type of system change you're driving for needs to be solved by politicians, that's not a great place to say data science is the solution. And so this is the type of framework we use when we start to assess where can DataKind be a leverage partner, and where can we meaningfully make an impact. So if the other components are there and data science is the unclogger, right? So if you just added data science, you would have greater flow of resources, greater flow of information, ability to solve problems for X more people. That's a great point for data science. But if data science creates a solution that sits on a shelf because you have many other people or many other decisions that have to be made before it's used, that's a place where we don't think the problem should be approached with data science first.
Great, and thank you for sharing that resource. Really helpful to have. So heard you all speak about really the need to identify, the appropriate data scienceable questions and pair them with the appropriate data science approach. Would love to hear a bit more. I know you touched on this in each of your remarks about some of the enablers. Once you have that data scienceable question or problem, what are some of the enablers to solving that with data science, and some of the potential barriers that we see? And maybe taking that a step further, how can the global community do more to support countries in applying data science to address those data scienceable problems? So again, I'll start with Manisha and move to Raghu and then Caitlin. You're on mute, Manisha.
All right, there you go. Thanks, Emily. I think each of us have talked a little bit about the barriers to this. So I won't go into that again. I think maybe I'll pick one and talk a little bit about how we are looking. And that's a critical foundational issue, right? It's basically, do we have the data to execute on data scienceable problems? So, I mean, if you think about sort of the three areas that we talked about, is that do we have the data, do we have the capabilities of data science, and then do we have the ability to action the insights coming out of that? And I think without having data, I think the next two, even if you have them, you're not going to get the complete value out of it. The one thing that we have realized is the fragmentation of the sources of data that sits into global health. We have, different systems, we have different applications, we have different disease areas that have unique needs. And if we take, what gets measured, get actioned, it gets into a vast world of metrics and reporting formats that creates a lot of data. It is unclear how good it is, how useful it is, and how timely it is. So it is not about the problem that I want to highlight is that it's not that we don't have enough data. We just may not have enough of the right data at the right time. And what do we do to solve that? And I think there are two things that the global community should and can rally around. The first is, how do we ensure who is using that data? Because the demand for that data, if it is coming from, say, donors, from a reporting standpoint, is going to look very different than if it is coming from a managerial standpoint. So if it is key stakeholders, and if I think about the three archetypes, they are demanding the data and they are using the data. It is in their interest, and they are going to ensure that that data is cleaner and timely, because they are in control of the loop, the information loop. That is a hypothesis that we have. I won't say that is strict around research, but that is hypotheses that have come from the private sector when they built information systems at the turn of the century. How do we ensure that people are using the data that they collect? Because then they're going to collect the data because they're going to use it. So that sort of virtuous cycle is critical. Being able to move away from demanding disease-focused data or sort of research data to actionable managerial data is probably a paradigm change that the public health group needs to move. Because if we are only looking at reporting data, and I will say this, that if you look at some of the data coming to the frontline data being seen at the district or national level, it is reporting rates. It is not that which is not an actionable data point. It's a lot of data, but it's not an actionable data point. So I think that is something where I would, maybe even, and this is not new, I think all of us know this. I think how we transition from the MDG, SDG area where we've built and got so much success through this infrastructure to the more sustainable integrated infrastructure, which requires, changes in discretionary power, how systems are built, and a new way of thinking about what are the right metrics that we need to ensure that change is happening. And I think that's a conversation that has started, and I'm very excited to be part of that, and hopefully will evolve and take us into the 21st century. Over.
Hi, I just want to add a couple of things. The core of the biggest is basically this. Large public health programs, global health programs, country programs don't, I'm talking about specifically the country programs generally, really need to build strategic vision and priorities around data, right? In data science, right? Without that, it's all going to be ad hoc, right? And that, by the way, that's one of the reasons why we are now engaged very closely, for example, with India's national TB program or the National Digital Health Mission, because the inside capacity is not there. Data science and AI is so new, there isn't yet capacity, and generally the capacity within the system lags behind. So you got to partner with them to actually set the strategic priorities and standards and processes for first data to come together, and also it to be present, to be used in a way that's actually like money. So it's, to me, it goes back to the point program, the core. If you keep asking why didn't that happen? Why? It comes back to the lack of strategic vision and paradigm around data. So that's the core, and that means understanding administrators and decision makers, understanding the value of that and investing time. And this community, I think, has to invest time in those conversations and those relationships to go inside and make that change.
I would add to that I think there are two things that the global community could very much push on, and one is sort of a central repository or central community of practice that is sharing the learnings of how to apply data science and the best data science tools in the space. I think Digital Square at PATH is a great example of these global goods, and I would push us to keep thinking about are there global goods in data science? You know, is there a predictive model that is truly generalizable to the greatest number of cases? Is there a tool that helps interpret and predict, say, forecast resource needs using DHIS2 data that should be shared out as a common add-on to the DHIS2 deployments that a majority of our partners have. I think that the community not only needs to be sort of a repository and a technical better, but the greater community needs to develop and share a strong point of view on the ethics of data science decision making. Just because we can do data science, should we? How do we evaluate the unintended consequences of data science solutions? A very practical example I'll give is this idea of using satellite imagery or drone imagery to identify healthcare cold spots. So if you take images of a particular geography and you identify populations that are, say, disconnected from the primary road networks, or they are isolated in some way. And with positive intent, oh great, I've identified this population. I want to be able to provide that last mile of healthcare to them. What happens if you surface locations of remote settlements, of temporary settlements, of populations that are undoubtedly vulnerable in some way, and that information is given to someone who could use it for nefarious means? What is our obligation as sort of the global stewards of these data science solutions, and what is our point of view as we put solutions out into the world? I think that that's something that we very much need to drive on.
Thank you all, and thanks, Caitlin, for raising that last point about some of those ethical considerations. And I think that ties in closely also to a question that I saw come in from the audience that's about ethics, but also about kind of the cultural perceptions of different data science solutions, and particularly for Raghu, thinking about AI solutions and how that might require kind of a mindset change, or how different cultures might understand those solutions differently. So Raghu, I wonder if you want to touch on that, both kind of the ethics piece and how we think about the ethical considerations of AI, and also kind of the cultural acceptability of AI or other data science approaches.
Yeah, so okay, the ethical both these are really actually vast topics within themselves, very honestly, right? There's ethics in everything from how you collect the data, right? The rights of the people from whom you're actually using that data, to using the data to provide, let's say, differential service. Is it ethical to prioritize in a new way when maybe the system was used to prioritize patients in a different way? So it's actually a pretty big body of deliberation that we have to consider when we are thinking about AI. That say this, there are precedents in medicine well set around how to bring in new medical devices or new drugs. We use a stage process of doing these things. I'm not suggesting we slow down everything, but I do think we need a stage-based approach. For example, when we build AI, we first, when we do a new setting, we always do additional validations. In fact, before we actually taking any active decisions, we do passive validations. We do lots of testing internally, and at some point, what we call external pilots, we actually bring external evaluators, even though maybe data standards aren't there that force us to do this. For example, COugh, we are looking at perhaps applying the ISO 13485 process. So there are things that are already available in medical science and global health generally that we can actually transfer pretty well to AI. It just brings up specific challenges there. Right? Now, with respect to acceptability and behavior, no different. You got to do usability testing. I mean, we have as part of our group design researchers. We understand, we actually invest in that design research and understanding user behaviors and attitudes before we go out there, and we address that as part of our overall solution design.
Great, thank you, Raghu. Manisha, did you want to add anything on this topic of ethics or ethical considerations in data science approaches?
I mean, I think, what Raghu and Caitlin said, I just want to continue to endorse it. I think we don't know a lot around, the use of information. I mean, there are, as Raghu rightly pointed out, the informed consent conversation is still evolving. How we, the quality of information or the biases within the information, the data, and how those inform both the analytics or the AI is also something that we need to be very watchful about. And then there is the entire body of potential misinformation, and that we are dealing with in real time in different ways. And I think just this is less around data science, but if you think about vaccine hesitancy coming forth in the COVID response work, I think there is a lot of questionable information that is going to be available, and how that is used in decision making or can be used for analytics, whether it is where the vaccine is deployed, how do we prioritize, and the political nature of those questions become a broader sort of ethical and convoluted question. So I think the one thing that I probably have added to that is, how misinformation, how data science can be used to propagate misinformation is something we're seeing in other sectors. Is this something that we should be worried about in global health? I think we should be concerned at the very least.
Yeah, at the very least, being aware of it and having that at the forefront of our minds. Great, thank you all. We had a really interesting question come through in the chat about sustainability of AI, and I'll extend this to thinking about sustainability of data science approaches more generally for decision making. And the question noted that, you know, we've been in similar pandemic situations previously, thinking about H1N1, Ebola, now COVID, and yet it seems like every time we start afresh. And I know, Manisha, you mentioned this in your opening comments, that the current pandemic has really brought to the fore kind of this need for data and data science approaches. So how can we think about ensuring that approaches that we're putting in place now are sustained and are in place to help mitigate the next pandemic? So Manisha, maybe I'd start with you and then move to Caitlin and then Raghu.
It's an excellent question. And I think sustainability, well, you know, writ large, is something that we have grappled with time and time again. I think where data science and data science approaches come in, how closely and how deeply they get embedded within the decision constructs of key stakeholders and countries is going to be an essential piece to it. In the go forward strategy. For the simple reason is, how essential is email to you now? How essential are technological constructs that have become mainstream in the work that you do day in and day out? If we can achieve those and embed those, as opposed to standalone shiny, you know, objects that are funded by X, Y, and Z or supported by X, Y, and Z, then sustainability will always be a question, because it is my system versus your system, my analytics versus your analytics, as opposed to analytics that are deeply embedded, regardless of where, you know, who's funded them or who has initiated them. So I think that deep embeddedness is probably going to mitigate changes in, you know, financing strategies, as well as political strategies, because it's always around, you know, sustainability comes into question when financing ends, or when sort of the political landscape changes to reinvent, you know, something that is under a new sort of banner or a new brand. So I think that is going to be a key area in terms of getting into the lives of and the workflows of key stakeholders, so they are depoliticized and made critical to day-to-day functioning.
I would add to that and say that solutions are not sustainable if they don't have buy-in and deep capacity to be sustained at the community level. So when DataKind starts a project, we go through an extensive co-design with our partner organizations, and we have some that we define as a project champion. So someone who is part of the implementing team, who is representing the community that will be receiving the solution as part of the decision-making process. And you know, for a team that is primarily US-based, it is absolutely essential to have this key team member in the communities that we are trying to serve. I think that it is also important to listen to the community representation of what is needed. I have a long background in Engineers Without Borders, and an example that we talked about a lot would be a community asked for wheelbarrows and we gave them tractors. But if you don't have the infrastructure to fuel a tractor or to fix it if it's broken, is that a better solution than providing wheelbarrows? And the same applies to data science. If you need a data quality assessment tool and I provide you this incredible predictive engine, that's not the solution to the problem you're trying to solve. So we, as the experts here, need to create solutions with the end users as part of our design process, because that is the only way to ensure sustainability.
I don't really have much to add. You got to involve all stakeholders, get deeply embedded, right, and work from the inside as far as the owners of these systems are concerned, right? Only when these workflows and data pipelines are embedded do they really survive. And they should show value on the ground as well as at the administrators level.
Great, thank you all. I think this is a great question to end on, to really think about how we continue to make sure the approaches that we're implementing are sustainable and really involving the end users and making sure that it's built into the workflows and really embedding those analyses in the key processes. So in our last couple of minutes, I just wanted to share and give you a preview of a bit of the work that our panelists have been doing related to what we're calling a health data science exchange. So you heard us talk a bit about some of the barriers to implementing health data science, and those include things like fragmented investments, lack of coordination, inequitable distribution of skills, lack of visibility. Caitlin mentioned this, a lack of visibility into what data science tools and approaches are really available. And these are all barriers that, we've heard great examples of how they've been overcome in some of this project work, but I think as a sector, they're challenges that we're still working to address. So the Rockefeller Foundation funded an exploratory effort for us to consider, could a health data science exchange be a potential way to overcome some of these barriers? And so we are putting forward this idea or concept of a health data science exchange that would really be a virtual space to bring together stakeholders, including, data scientists, as well as public health practitioners, and really build that community around data science and bring more visibility into what are the data science tools and approaches, both on the demand side as well as on the supply side. So on the demand side, thinking about can we have a problem stack that helps to identify some of those data scienceable problems that we talked about? Can we gather and make available in one place more of these translation resources or operational guidance to help people kind of pick up and use these data science approaches that have been proven in other contexts? And on the supply side, can we have more visibility into what those data science assets are? So having kind of a list of data science tools, approaches, resources that have been used in other contexts. So this, we are having a launch of this health data science exchange concept on October 6th. So we will follow up with the Global Digital Health Network to share out the details for that. But just wanted to make you aware of that and to thank our panelists both for their engagement today, as well as their participation in the advisory group to really shape this health data science exchange idea. So with that, I will hand it over to Christina to close us out.
Great. Thank you so much, Emily. And thank you to all of our panelists. This has been a really, really exciting and kind of deep session on data science. I've been like taking notes and like jotting down ideas. So I really appreciate you all taking the time to present on our meeting today and to come together on this really important topic. And I as a co-chair of a current community of practice, I think that I'm really excited to see this health data science exchange kind of coming up. I think the more we can share and collaborate, the more we will continue to break down silos and be able to better coordinate investments in digital health. And that's something that I've really appreciated about this field overall of digital health, has been that kind of spark to continue to collaborate and coordinate and not duplicate efforts. So I'm excited for this launch on October 6th. And to see what you all continue to do, please keep in touch with the network as you guys continue on and we can find ways of collaborating. So anyways, I just wanted to thank everybody for attending today. And again, a big thank you to our panelists, and we will talk to you in October. Have a great rest of your day.
Thank you.
Thank you.
Thanks, everyone.
Thank you.
Right.
Ready?